Okay. Good afternoon and welcome to the Black Health Trust weekly program. We're so pleased that you've chosen to empower yourselves today by joining us. It's great to have our regular attendees back and those new to the program. My name is Janelle Maxey and I'm your hostess for today. I hope you all are doing well from wherever you're joining us from. Today, our panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation and President and Founder of Black Health Trust. He will introduce his terrific co-moderator and guest presenters today. Black Health Trust was founded in response to the global pandemic and Dr. Maxey's desire to keep his own family safe. And fortunately for us, his commitment evolved into a much larger vision. The purpose and mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines to offer unvarnished opinions and insights into our physical and mental health during these challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioners. Now I will share a few housekeeping items and announcements for the program. This video conference is a live program and being recorded on different public platforms such as Facebook Live and YouTube. Your participation on this program is completely voluntary, and if you choose to participate and prefer not to have your image and likeliness displayed, there are visual and audio settings on your personal device that you can use to block your picture and mute your voice. That said, all participants will be muted by our Zoom technician initially. We ask that you remain muted until the host or moderator asks you to contribute in order to minimize the distraction of background noise so that we can give 100% attention to our speakers. Check and make sure your device is on mute until called on to speak, and then once again, place your device back on mute when you are done speaking, please. With regards to the chat room, if you have any questions, you can enter them into the chat room, but please limit your questions to 2 questions per topic being addressed, and please do not use the forum to advertise or promote your products. Understand that there may not be sufficient time to get to all of your questions, but we will certainly do our best. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult with their own legal or medical professional for conclusive guidance on how to proceed in your own personal circumstances. We're in this together. If this program has been valuable and interesting to you, please visit the website to learn more about our program and how you can support Black Health Trust so that we can continue bringing our community outstanding content. Please visit www.blackhealthtrust.org. We want to thank the Black Health Trust Steering Committee, the Executive Board, its virtual administrative assistant, our production and Zoom technician, the Black Health Trust supporters, and all the people behind the scenes for their time and efforts that make the program possible. Let's now welcome all of our distinguished physicians and special guests. We thank you for sharing your valuable time, information, and educated insights with us today. Your participation and support help to empower our communities of color, and this is critical to our present and future well-being as people. Black is beautiful and knowledge is power. Welcome again, everyone, to Black Health Trust weekly program. This is our community. This is our time to take our health, so lean in. Dr. Randall Maxey, please do us the honor of beginning today's program.
Thank you so much, Janelle. We appreciate you. And as you said, your thing about power and knowledge, I like to say it's better to be distinguished than extinguished. So that's where we're going to start. Good morning, everyone. Welcome to my co-moderators, Dr. Barbara Neighbor-Stevens and Dr. Ivan Walks. I appreciate your partnership with me in putting this together. We have an excellent program today. The producer of today's program is Dr. Helen Davis, a distinguished and well-known ophthalmologist from the East Coast who is now working in California. She likes the weather here better. So we're going to start. I'm having a few technical problems.
Uh-oh. Well, I'm going to jump in until Dr. Maxey is able to rejoin. I am going to proceed with introducing my partner in this endeavor, Dr. Walk, and then we will proceed with the introduction of Dr. Davis, and she will begin the program. Now, for those of you who are our regulars, you will recognize Dr. Ivan Walks. For those of you who are new, let me introduce him to you. And I try to highlight a new fact each time I introduce him. And today, it is my pleasure to share with you that Dr. Walks, who was trained in California and is a board certified psychiatrist, has had a very diverse career. He has contributed to something that many of you may not be aware of, but I can tell you it impacts our lives every day. Dr. Walks was appointed by President Clinton to the board of the National Mental Health Awareness Campaign. And that group was primarily responsible for getting the mental health parity law passed in this country. Now, for those of you who may not know about the mental health parity law, up until the passage of this law, there was disparity in the way insurance covered physical health issues versus mental health issues. As a result of the work of this group, insurance companies are now mandated to provide equal mental health services as well as physical health services. Dr. Walks has formerly been the health officer for the District of Columbia and is currently the CEO of his own consulting group. Next, I'd like to present Dr. Helen Davis. Dr. Helen Davis is a board certified ophthalmologist, which means that she specializes in diseases of the eye. She completed her undergraduate studies at U of Michigan and medical school. We are co-alumni of Tufts University School of Medicine. She completed her residency at Bascom Palmer Eye Institute in Miami and has practiced for many years in Pittsburgh, Pennsylvania. She is the founder and medical director of Project Total Eye Care, where she and volunteer staff have delivered years of outreach eye care and humanitarian services to the poor, disenfranchised, and elderly populations in Western Pennsylvania and elsewhere. She is now located at and works at the Kern Medical Eye Institute in Bakersfield, California. Dr. Mack, have you been able to join?
Okay. And I did get extinguished for a moment. Thank you for coming in. And we will begin our program. I'd like to give some statistics early on just to monitor where we are in the process of doing it. I usually refer back to November the 22nd, just for perspective. Can you go to that first slide, Simon? And in this slide, it shows that we had 11 million cases, 843,493 in the United States at that time, with 253,600 deaths at that point. And if you look at the next slide, as of today, there are 26,653 cases and 558 with a total deaths of 457,762. And the number that we're going to focus on today is that there are 39 million vaccines administered in the United States. But I'm glad to understand that less than 5% of this number is done in the African American and other communities of color because of vaccine hesitancy, but also because vaccines have not been available. So our panel today is going to address some of this, and I'd like to introduce our producer for today, Dr. Helen Davis, who has been introduced in detail by Dr. Neighbor Stevens. Dr. Helen Davis, welcome. How are you? Is Dr. Helen Davis on?
Yes. Good afternoon, and thank you all for inviting me to produce the show. And also, I would like to welcome everyone on the Super Bowl Sunday for this super important discussion and of high concern, and that is a national call to action to bridge the vaccine disparity gap in African American communities. You highlighted some of the statistics, and I just want to summarize again, just for people who may have joined in at different points. Okay, vaccine inequities are here, but the vaccines are here, but where are the vaccines? Okay, I'd like to share my screen. Okay, we need to, the host needs to open up my screen.
You can go ahead.
Okay, a national call to action. Well, it's a shame that America is one of the worst hit countries for COVID. And that's because we had, as you know, a delayed response. Now, the COVID vaccine is the highest vaccine campaign in history, yet the US remains the worst hit country in terms of cases. We outnumber even third world countries. Per Dr. Foster, we need to be on a path to immunity, because without immunity, it's impossible to control the virus. Well, the problem is many locales across the country are reporting unequal access to the vaccine, and reportedly 11.7 doses have been administered per 100 people in America, and that's 60% of the shots delivered to all states, but yet and still, like Dr. Max has said, it's not getting to our community. There's been unequal access across states, counties, certain municipalities, and even zip codes. This inequality of distribution is may cause the communities of color to have an immunity gap, which means that we cannot fight the virus if we can't get immunized. So this call to action is important because racial minorities can no longer sit on the sidelines and just wait. You know, older Americans are disproportionately white, and of course, they're receiving the lion's share of vaccines. Now, essential workers and frontline workers are actually a larger percentage of racial minorities and low-income people. But these are the people not getting vaccinated, and they also represent a higher coronavirus fatality. Now, of the states that have released the vaccine data, 17 out of 50 states show that with populations like in North Carolina, 22% Black, only 11% have been vaccinated. Or in Maryland, where you have 30% Black and only 16% vaccinated. And these are the ones that were proud to show their data. So can you imagine the ones that did not show the data? And of course, there are a lot of states and cities that did not release their data. So there's claims of selective vaccination, claims of disadvantageous screening and scheduling by race, with Blacks not being able to get appointments or vaccines not being available in their zip codes, or even suspicion of purposeful hoarding, destroying, or maybe even black market sales. Well, we have a new administration, a new COVID task force, a new plan for rollout. But for sure, Biden inherited non-uniform and an inequitable plan for distribution. He also inherited a shortage of supplies, and he inherited misguided policies based on unscientific political exigencies that cause serious public harm. But on the encouragement note, he is stressing to target vulnerable populations and equitable distribution and more easy access. But we got to be in it to win it. So Black people, African Americans need to be in the race for preferential vaccination and boosters if needed down the road. We need the golden ticket. So here I come to our audience, as well as our speakers, to ask, what can you personally help to do to bridge the vaccine disparity gap in your respective communities? And we call on the speakers to help us for strategies to help overcome vaccine hesitancy, how to mobilize trusted advisors, how to fight disinformation, how to demand equitable distribution and equal access. We need a plan to overcome vague timelines and complex distribution plans. So in a race to end the pandemic, we need to, as we say, get in line, make demands, and make people accountable. So I'm asking the panelists to discuss interventions and strategies needed to reduce the vaccine inequity gap, as well as to increase access, as well as increase uptake. What's working, what's not working, and let's get a plan of action for this super important dilemma that needs to be resolved. Thank you very much. And I'd like to bring forth our first speaker, Dr. Willie Gaffney.
Dr. Davis?
Yes.
I'm wondering if I can make an executive decision.
Sure.
One of our participants is actually on the front line giving vaccines today, and he had a time constraint. I'm wondering if it's okay if I can put Dr. Abraham, you have your time constraint, is that correct?
Correct. I'm available, but I'm also trying to make sure we have enough inventory to get through tomorrow and the rest of the week. So whatever we can do, I want to be on as much as I can and answer any questions, but I'd like to share some narratives and stories from the front lines if there's a moment.
So if it's all right with Dr. Davis, let me change the order of the program and put Dr. Abraham on now. And because he's out, he gave me my shot. I got my second dose of Mrna just last week, and he had a crowd wrapped around the block. And I do have a concern about who composed that crowd wrapping around the block. But Dr. Abraham,
well, he is doing what he's supposed to do. He is calling to action. He is heeding to the call.
So
and
would
Dr.
Would you read his introduction?
Yes. Well, Dr. Abrams, as an epidemiologist, is on the front line, but he is also an expert in the branch of medicine, which deals with the incidence, distribution, and possible control of disease. Dr. Jerry P. Abrams, MD, MPH, and CMQ, is a family and community medicine physician and global injury epidemiologist, caring for patients and serving the community at Kedron Health in South Los Angeles, where he also serves as director of the vaccine program. So we have someone who's actually out there distributing the vaccine. He knows what this is about, and he's in one of the hardest hit counties in the country. Dr. Abraham, please proceed. Please unmute Dr. Abraham.
Perfect. Hopefully you can hear me. Helen, thumbs up.
Yes.
Good. Perfect. Thank you all. Thank you for taking your time this Sunday. to really focus on an issue that is nothing short of life-saving essential medicine, this COVID vaccine, that everyone, when it is your turn, roll up your sleeve, take that shot. And that's my message. That's my mantra. So maybe you've seen from some of the media opportunities we've had to share our story. It's really not about Black hesitancy. It is really about not enough vaccines, not enough people to administer them, and not enough resources to do it. People who have come here, like Dr. Maxey and several on this call right now, have rolled up their sleeves and done just that. Access is critical, and let's not confuse access for why I didn't get my shot. And don't make assumptions about why my community here in South LA didn't get their shot. And the reason at the end of the day really boils down to it's just not enough vaccine for everybody. And that's where we start to get into these weird, strange priorities, phases, and tiers. That's just not where we need to spend, focus our energies. We need to figure out why we don't have enough, and tell whoever can to get it here. And you get as many doses of vaccines to places like Kedron, to King Drew, to other parts of South LA, to Dr. King's office, right? To the Charles Drew Medical Society and Dr. Goffney and the work they're doing. We will get Black and Brown, South LA, and all of this county vaccinated. That is, period, the main message today that I have to share with all of you. And so I want to answer any questions and I'll be available, but I'll just tell you a little bit about our story. You know, we're here at Kedron in South LA. We're a health system that includes an acute psychiatric hospital. We have outpatient mental health outfits. We're a patient-centered medical home with family medicine and primary care clinics. We go out into the community and do our field work to keep people out of prison and get them reintegrated when they are on parole and when they are back into the community. That is what we do. That is who we are. And then coronavirus happened. And we didn't really have a choice. And it's just like the 1960s when the Watts riots happened, and there was not a place for Black and Brown people to get mental health care. And that's how Kedron was started. Likewise, we knew we had to do something. So as early as March, we got involved in the city and county testing. And as soon as the emergency use authorization of Pfizer and Mrna started back in December, this is the week before Christmas, we knew we had to get involved in this operation. What was heartbreaking for me was no one had contacted us. So how do I have nurses? How do I have patients with COVID? And no one had reached out. When will we get our dose? Meanwhile, Dignity Health, Kaiser, UCLA, USC, they had all been starting to roll out their vaccines. And like we've already heard on this call, all sorts of people lined up and got their vaccine. They rolled up their shot. But meanwhile, they're working from home. They're doing telemedicine. They may not really be in priority groups, but the wrong zip codes got it right away. And somehow they didn't even contact us. And that's when I started asking questions. I asked questions here at Kedron. What's going on? Why don't we have any? And then one question led to the next. The next thing you know, we're at the Department of Public Health. What happened? Why didn't we get any? And I'm in a Kedron van going to the Department of Public Health and what's going on? Why didn't we get any? I'm knocking on doors. And I said, we're not leaving until I get some, and we're going home with it. And we're going to give it to our staff, but that's not going to end there. We're not here in it for us. This is not about us. I want to protect our staff critically, but we weren't going to do this unless we can protect and help all of our Black and Brown healthcare workers in South LA. Unless we could expand this rollout to Black Brown seniors, aging people 65 and older in South LA. We weren't going to do it unless you gave me enough vaccine to make sure that we could make sure all the essential people that are exposed to COVID on a regular basis, that are getting infected and that are dying, could get this vaccine. And I think that was a very different part of our story. I saw facilities line up and say, give me enough so I can take care of my staff. Give me enough so I can just take care of my nursing home patients. We said, don't give me any unless you're going to give me enough to take care of my brothers and sisters. And then when it's time to take care of our grandparents as well, right? And that was a very different part of the narrative. So that's probably why we've been so successful that as of today, we've distributed over 20,000 vaccines into the arms of people. That's a very different narrative. Some of these megapods that have failed. We have not allowed barriers such as no email or no cell phone. We have not allowed barriers such as I don't have internet. We have not allowed barriers such as I don't speak English. We have not allowed barriers such as I don't have a car to stand between you and your dose that your taxpayer dollars paid for, right? And that was the big difference between what we did here in Kedron and in South LA and what you're seeing very differently from the rollout in other places. And people are taking note. People are taking note at the county, people are taking note in the state government, and people are taking note at the federal government level. And that's critical because we can and should do things differently. It is not just efficient, but it has to be effective and right and fair and just. It can't just be about data entry. It has to be about people first, and we'll get you your data too. And that was the problem. They were putting all these competing interests on people that are trying to do good work by vaccinating people. So no wonder no one's up to this challenge. We're not even up for this challenge, but we weren't going to quit. But they made a lot of challenges and hurdles, and little by little, because we're up for the fight and the challenge, we've told them we're not going to let those things stand in the way. So we created workarounds. We've created paper forms. We have data entry clerks around the clock at night putting in information. We are getting the state and the feds and the county what they need, but we're most importantly making sure that this vaccine ends up in the arms of as many people. Another mantra that we've had here at Kedron was, we don't think this is just a hesitancy issue. Whether you are white or black, this is scary. It's a new technology, an mRNA virus. There are many questions to be had. This is no social experiment. This is not Tuskegee. This is not Henrietta Lacks. This is an FDA authorized vaccine that is for everybody. And everybody was involved in the trials, and the NMA watched closely. So when we talk about those questions, it's really, we haven't educated people. We haven't engaged them right. And when we do that, they will do what? Roll up their sleeves. They will get vaccinated, and they'll come back in 4 weeks for their second dose. Lastly, the other thing I want to leave with you is Johnson & Johnson is on the verge of an FDA authorization and the EUA. Whatever vaccine comes for you, you roll up your sleeve and you take that. This is not Pepsi versus Coke. This is not KFC versus Popeyes. None of that. It is a vaccine, a life-saving essential medicine, and they all meet the main standards. And don't worry about that immunological effectiveness. You focus on equitable survivability. And until Black and brown people are surviving COVID, just like rich people and just like white people are, then the only thing that matters is get as many vaccines into our many people. And that's the message. More vaccines, more hands to deliver them, and more resources to do it. And that's the only thing that we're going to focus on here at Kedron. We promise this administration, the Biden administration, in those 100 days, we are ready. We are committed. Let's run 1 million doses in 100 days. We can do that from Kedron. You just get me enough vaccine. And that's what I got to share with you today. So thank you so much for your time. But know that we are all working around the clock, and I can't thank everybody at Kedron. I can't thank the board. I can't thank everyone who has worked tirelessly to get to where we are. But more vaccines, more people, more resources, I promise you, we could do so much more. We can come to. And you know what? This is really getting at the heart of the true health equity. There's an opportunity here. Crisis is what? Disaster plus opportunity. And we're going to right now answer some of those challenges and gaps. It's just that this COVID and this vaccine has highlighted, put a spotlight, a flashlight where there was darkness. And we're doing that now. We're going to change the narrative, and this will be the start. An opportunity like the Phoenix will rise. We will change healthcare delivery for the Black and brown communities of South LA, for those socioeconomically disadvantaged here in Los Angeles County. We will build truly a healthcare delivery system built upon historically Black institutions like Kedron, committed to improving the health of all Angelenos. So that is my message today, and thank you for the time.
Thank you very much for a very passionate appeal. And I think you hit the point that we can't make excuses. We need the vaccine, we need the resources, we need the help, we need all hands on deck. And this is what this national call to action is. Come out of your comfort zone, physicians as well as other community advocates and healthcare advocates, and help out. Help bring them to the clinic. Help give somebody a ride. Help a senior out. And this, we have to be in the trenches to win it.
May I ask him a question before he has to go? Doctor, a few days ago, we talked about taking it to the people. And you mentioned getting buses and trucks and taking it to the churches. Can you expand on that? And we had a pastor on from New York, Buffalo, and he talked about the program that he has reduced the COVID number and the death rates we need to put something together like you're doing and put it on wheels. Can you speak briefly about your thoughts
Yeah,
around that?
absolutely. Who is forgotten and who is left behind? I already mentioned the hurdles that we are overcoming here, but how many people, even with those workarounds, aren't going to make it? Homebound seniors who never leave their house, but they got folks coming in and out, kids going to school, they've got people, essential workers coming in and out. They are absolutely vulnerable. So I call this Kedron 1.0, where I commit that we can do 2 to 3, even 5,000 injections a day. Kedron 2.0 is Kedron South. Kedron 3.0 is building this apparatus at King Drew and making sure that everyone in that zip code and that area has access. But Kedron 4.0 is Kedron Mobile. We are building a fleet of vehicles. As soon as we have approval from the county and the state to be able to move vaccine, there's a lot of red tape and challenges about what they call reallocation and allotment. A lot of it has to deal with temperature management, storage and handling, transport issues. Those are the barriers that I will overcome. But Kedron 4.0, we will build a fleet. I call them the ice cream trucks. We will go into the community and we're coming for every grandma and grandpa and every adult that can't leave their home for all sorts of reasons. They're the ones that need that vaccine, and it's not their fault that they can't get to the places where they are. So let's not blame people. Let's build that fleet. Let's go to them. Let's take that vaccine. Let's convince those policymakers that the right thing to do is stop building these megapods. It's great, and I love it, and we need more of them. We've got millions of people here, so every megapod's needed, but so is every van and every ice cream truck that we can put vaccine in and go to every church, every library, every community center, every elder's home who can't go to any of those places. No one should not get a vaccine for those reasons, right? So that is really, to Dr. Maxey's point, partnerships with faith-based organizations. Absolutely. Let's go to those churches. Let's educate. Let's engage. Let's vaccinate. I promise you we'll answer their questions. When people come here, I always say there is less than 3% vaccine hesitancy amongst Black healthcare workers that I've seen here at Kedron. When we do all the right things, the only people that don't get a vaccine here from Kedron really are those with true medical contraindications. But if you take the time, you explain the science, you legitimately answer the questions, we're not going to have to fight this thing. All we need is to actually make sure we have a dose and that we get it to the right people. And that's where, to Dr. Maxey's point, absolutely. Those that can't get here, we need to go to them. And that's where we need to have a mobile fleet with vaccines. And that requires approvals from several layers of government. And we're working on that right now.
Are there any questions from the chat box, Janelle?
Well, there's one that I want to get out there because I think it would be helpful to others who are trying to initiate efforts in their area. So exactly what type of employee are you utilizing, or are they volunteers to do the education and the outreach in your program?
It's a great question. I will say first and foremost, we have nothing but praises for people here at Kedron, nothing but praises for the Department of Public Health and for the state government that have really done everything they can to help us. We have people that are just working around the clock. They're doing jobs that they are not paid to do. They are helping and holding hands. They're getting seniors out of their cars, into the freaking tents, getting them vaccinated and out, answering those questions, taking the time. But because of the momentum, it's kind of like a vaccine breeds another vaccine. We now have the governor's office caught wind of what we're doing here. They got California volunteers involved. They got AmeriCorps involved. They got the American Red Cross involved. Now we're talking about the National Guard. So that's a big part of who is helping, who's not Kedron employees. When we move beyond that, we have plenty of people that are grassroots community organizers, many from organized labor, who have stepped in and stepped up, and they are here as extra hands. But of course, we've got to be extremely careful and mindful. We are a healthcare facility that first and foremost cares for Black and brown mentally ill here in South LA. So safety is critical, making sure that people that come here are vetted and approved. That's a challenge for sure, because we need more hands, but we need the right hands. We need people with the good heart and want to help, but they need to be helpful. So that's are all kind of challenges. In terms of your education, that's where pastors, that's community leaders play a role, because you get vaccinated in front of your congregation and you tell them why you did it. You're a diabetic or a cancer patient or someone who has an illness. who got it, who believe that actually getting it helps you versus you're scared to get it because you didn't know if it would adversely affect you. Now somebody who's in your same shoes goes, well, if they did it, then I can do it too. And it makes people braver. Makes people want to say, I want this vaccine too. So that kind of helps answer a little bit. But yes, I mean, it is a hodgepodge of people that just come here. You know, patients are coming here with their arms, their sleeves rolled up, waiting to get a vaccine. Well, I've got plenty of volunteers and healthcare workers and Kedron employees coming here with both their sleeves rolled up saying, put me to work, right? So, but we need more of it, and we're going to have to keep building on that. Right now, I'll say the bigger proposals are there definitely multinational or larger foundations that want to look at specifically the engagement and education piece, working the mayor's office and the governor's office specifically on hesitancy. It may include making, you know, whether it's music, whether it's having celebrities come and have them documented and videotaped getting their vaccine and share why they did it. There's all these strategies that might help, and we just don't have enough time in the day and enough resources to do it all. But all of it, yes, all of it is, and all of that will help us get to where we need to go. The faster we get to 70% plus of the population vaccinated or having strong immunity against COVID, we really can get back to our lives, back to opening the economy, back to loving our loved ones and hugging them. So that's all I got to say.
Let me throw you a quick challenge. On this call, you have a number of past presidents of the National Medical Association. You have the current president-elect of the National Medical Association, the president of the Charles Drew Medical Association, I think even Mound City Medical Association. And I understand when you mention celebrities, we have Miss Patrice Rushen, famed jazz flautist on. What are you going to do with all these people? How can we take your passion and make it work across the nation? You've got a big listening audience of maybe over 7,000 to 10,000 people. What do you want to say, Doctor?
Sorry, I was muted there for a second. What I'll say, I mean, I have this fantasy that we're going to make a rap song or a song or something, a viral music video that, you know, really appeals to the Black and brown community, but clearly it goes viral and global. And I think once we make it cool, just like you go wait in line for your sneaker pumps around the corner, I want people to wait in line and want and demand. This has got to be the cool kids now, right? And there's a way to do it. I see what they did in the 60s with smallpox. They hopped on motorcycles and they went, nurses and doctors all around this world, vaccinating people against smallpox, and that's how they eradicated it. For us, our toolbox isn't those motorcycles and those helmets and those doctors and nurses going around. I think it's going to be social media. It's going to be people in entertainment. It's going to be people that get people through the hype and the memes and the songs and the sounds and the sights that appeal to the masses, because I think some of the information we're delivering, and you're getting all sorts of mixed signals from the media. So how do we control some of that narrative? How do we control some of that messaging so that you hear the right words? And there's a role for music to play. There's a role for celebrities to play. I think that's what we need to do. And I think if we come together just like they did around some of that Unite, what was it? The global aid around AIDS. There's all this advocacy around hunger. I mean, if you remember how many people came together and changed the world around world hunger or the HIV/AIDS epidemic or others, that's the type of movement we got to build. Build it here from Kedron. I'm welcoming everyone to come here, make their shared music video, get their vaccine here, and make that and make everyone excited and proud to be a part of the movement. Everybody has to do their part. Wear your face mask, clean your hands, get your vaccine when it's your time. That's how we will get back to our regular lives. And this ain't going to be the last time that we as a people, a species, deal with these types of challenges. And the better we learn how to overcome those challenges, we won't have to go through this 2 years out, a year and a half, 1 year. Today's the 1 year anniversary of the first US COVID-related death. I am tired of dealing with COVID. I am tired of seeing my intensivist and other colleagues managing ventilators. I'm tired of seeing Black and brown people dying in the hospital from COVID. We've got to learn how to do this faster, and we could have and we should have, and there ain't no more time to drag our feet. So do your part. When it is your turn, you roll up your sleeve, you get your shot. That's all I got to say.
Dr. Ivan Walks, Dr. Neighbor Stevens, are there any further questions or comments you might have of Dr. Abrams?
There's a question in the chat I'd like to get out, if that's okay.
Go ahead.
Someone asked, people with sickle cell and pregnant women were not included in the clinical trials in any of the three vaccine makers. What can we say to them about the impact?
I'll say right now that the American College of Obstetrics and Gynecology just came out with their latest recommendation looking at the data as of today, where there were several millions of people now that have been vaccinated, including many pregnant women and breastfeeding women. The recommendation still remains that women and breastfeeding women are absolutely recommended, if not strongly encouraged, to get this vaccine. As far as sickle cell, there's more data being collected on it specific, but it remains right now, it is recommended in my mind. Recommendation that holds true for immunological diseases, rheumatological diseases, other autoimmune conditions. The concern really is that they may not mount as strong a response. So the older you are, the sicker you are, the more critical that second dose or even boosters are, right? So that's actually what you got to think about. It's not that this vaccine is a dangerous thing. It's that the young and healthy mount a very strong reactogenic response to the vaccine. So that's why you see some of these young people that are like, I move my arm, I'm feeling chills, I feel under the weather, I need to take some Tylenol or ibuprofen, and they'll be fine. It's the older folks and the sicker folks that aren't actually quite having that response, and that is a concern. But what we've seen is effectiveness, and whether it's effectiveness at 70% versus 95%, the more people that have the vaccine, the survivability of infection goes up. You and I can manage a cough and a cold. What we can manage is being put on a ventilator, and definitely what we can't do is come back to life in this life right here and right now. So that's what this vaccine does, whether it is going to work really well in you or not extremely well because you're maybe perhaps a little older, or maybe because you have other comorbidities. That immunological response, how little it is, provides you protection. And the more people that have protection, the less this virus is able to spread from person to person. And that's really how you truly bend the curve. And now you've got an infection that is no more malignant than the common cold, where you don't got to go to the emergency room. You don't need a check spray. You don't get a pneumonia. You don't need to be in the ice. You don't get a ventilator, and you don't die.
So Dr. Abraham, thank you so much. This is Dr. Walks. I wanted to get back to something Dr. Maxey said earlier, which was who was in that line that went around the building. We hear a lot about vaccine hesitancy, and I think you're making a tremendous pitch for us to get past that and get in line when it's our turn. My question is about the people whose turn it is not, that are getting in some of these lines in our communities, and the responsibility for the folks who are giving the vaccines to make sure that they don't take up the vaccine that maybe is needed in our community. So if you can speak to that.
Yes. And Dr. Walks, I believe your background is psychiatry. Is that correct?
Rumor has it.
And I know Dr. C. Freeman has spoken on this particular group, the Black Health Trust, about the mental health burden and COVID and this vaccine. So I'll say people in those lines are scared to, and I won't fill in the blank, but you know what I mean. There are a lot of people, they don't camp out there because they're having fun. They're not camped out there because they're waiting for some concert tickets or from sneakers. They're camped out there because they think they're going to die from COVID. So I think every person that gets vaccinated with their sleeves rolled up and are ready to go, we do whatever we can to get everybody vaccinated. That's the truth. What you see outside, and that's changed since those very first days. Those very first days, you may have seen a different demographic, but I'll tell you, you see that demographic because we didn't let them in. What you didn't see were Black and brown people because we prioritized every grandma that came up there, came right in. You don't stand outside. You're an essential healthcare worker that is Black and brown. You came right in and you went back to work because you're doing critical work, saving patients, like Dr. King's staff, Dr. Tony Chavez's staff that came and went. They don't come here and wait in line. So so you see a bunch of wealthy people. So you see a bunch of white people wrapped around. You better believe it. They're standing out there because we didn't let them in, right? And that's not because I don't want to. It's because we don't have enough vaccines. And right now I got to make sure that where the infection is who gets it. But I will tell you this much. There was a story this week when one of those guys that I made those assumptions about who he was, and I found out he camped there because he's a homeless man. Nobody put him in their camp. He had no shelter he could go to. He's living in his car, and the only thing he can do was stand there, and that was affecting his mental health. He's this close to a breakdown and becoming a patient in my hospital versus he's going to stand there for 3 days. He was lucky enough. We did everything we could when we get to those last doses, which we're doing more to coordinate with Congresswoman Maxine Waters' office and with County Supervisor Holly Mitchell's office, we're building a call system through the mayor's office where, you know, there'll be like a priority call list. So that way now we know 30 doses, is there a retirement home? 30 doses, is there a church we can go to? And also now the county wants us to go directly to Skid Row. Once we get the mobile fleet, we'll know we have this much excess dose, this much time because of the expiration time, you know, 6 months in the freezer, 3 months in the, 6 months in the freezer, 30 days in the fridge, 12 hours outside. You punctured, you only got 6 hours. There's a lot of these funny timelines, which is why somebody says, how did you have an expiring dose at 12? Well, that's why. Why did you get 600 doses at 5 p.m.? Because nursing homes dumped on us because they didn't know what else to do, where else to go. Nobody else would tell them. And I told them, don't be afraid. You don't need to tell anybody anything. You those expiring, I'll make sure they get into arms. Unfortunately, there are times when I have to go outside and I have to count 1, 2, 3, 4, 5. Come on in. I've got 5 doses that I'm not going to put into the ground. And you were there waiting. And one of those guys was a homeless man that camped out for 3 days. And I made assumption because of his color and this and that he was doing it. And when I heard that story and how much I alleviated his mental health burden, that too is a price of this epidemic. And that too is the antidote that we are providing from this vaccine.
Let me answer a question, Dr. Walks, that politically I think Dr. Abrams shouldn't answer, but a number of pastors from certain communities that were not Black were busing their membership down to the Kedron area. And even though we're physicians and have to treat everybody, we know that our pastors have not done the same. If that answers your question.
Okay, thank you.
Dr. Neighbor Stevens, you had a question or comment? Dr. Helen Davis? Any questions for Dr. Abrams before he goes back to serving our community?
I just want to say that that this picture is not unique in terms of people coming from other zip codes to get vaccine that's earmarked for people of color. I know in Florida, what stimulated my interest in looking into this disparity, my sister could not get a vaccine in Seminole County. She's over 70, and everywhere she called, couldn't get a vaccine. But yet still the snowbirds were able to come in and get the vaccines in Florida and also in designated Republican counties. And so, I think that what you're doing is strategically important, and you're standing up to the political concern to address it. But I'm thinking in a lot of other cities that that the Black people of importance or power or the power brokers are not standing up to this. And I think that a lot of Blacks are not getting the vaccine because, like you said, the whites are getting it because, they're over 70, they're the larger percentage of the population, and they just have access. And I do know that uniquely that in Florida, a lot of the vaccines were distributed to Publix because the person who owns Publix donated to the Trump campaign. And so they get their allocation, their allotments in the Sarasota, Bradenton, high-end counties. But over there in Seminole County, where you got heavily Black Latinos, they couldn't get it in a lot of other community areas. And so we have to make our public officials aware of it. And my sister went to her congressperson, and her congressperson told her to go to ACLU, and she did. And so they're making waves down there. But she told me, she says, well, we're still working on it over here in my zip codes, but I'm having to go over to 2 counties to get my vaccine because I'm going to get my vaccine. But we shouldn't have to do that. We should be able to get it in our neighborhoods, and we need to mobilize our pastors and otherwise who already have access to buses and congregations and other political inroads to participate in this drive as well.
Yeah, Dr. Davis, I'll just add really quickly, Dr. Goffney and Dr. King know, they know I'm here from early morning to late night, and I leave every day. I'm telling you, there are tears flowing. It is very stressful. I don't know how much longer we can do this. There's never enough vaccines at the end of the day. There is a lot of pressure. They don't let them these workarounds. They don't like getting people through and in and fast, but that's what it's going to take. And so there aren't enough people that are willing to think outside the box, but it is a risky move, right?
Right.
Every day we do those things, it threatens this operation here at Kedron. They say, well, now you're not doing it according to protocol. Well, guess what? Digital natives and tech hipsters cut the freaking line to get appointments. So if you tell me to stick to
Absolutely.
appointments, then screw
Absolutely.
that, then I'm just going to end up with rich kids coming through. So
That's
I said,
right.
I ain't going to do that, right? So their appointment system's broken. So you tell me to do the appointment systems and not let
Appointment
walk-ins
system is
through?
broken.
You better believe it. And so every day I'm threatened that I'm not doing it right?
Right.
Every day that I'm threatened that I'm not supposed to use any sort of paper trail because everything needs to be entered into the computer. And I always say, what internet, what phone, what email, documented workers, what driver's license, right? So it's all sorts of nonsense that you're up against, but you got to be willing to fight. It ain't going to happen. Another point that you bring up, Dr. Davis, is I noticed some of those earliest, that first LA Times story that Dr. King wrote the letter to the editor to about, as you know, Miss Julia Wicks saw those folks out there. They were Uber eating and they were playing video games and it was a party. But there was something that clearly got out, and whether it was their social media networks or their social networks, they knew, come stand at Kedron, there's a chance. We need our networks to be just as powerful. And we're working on that with the mayor city and with the faith-based leaders and the community-based organizations, because our network should have been just as fast. So they didn't even, we didn't need to push them out of the way. We would have been first in line anyway. I noticed that the Vietnamese churches and Korean churches, they put on, they blew up, go to Kedron, here's what you need to do. And then all of a sudden we had Korean churches, pastors, Vietnamese priests coming here with their droves, all their seniors that came in and out. And we're working on that. Now Maxine Waters is bringing, you know, busloads of people. We've got people from all the nearby surrounding community centers. Councilman Price's office is doing something very similar now. But I did notice different communities kind of responded quickly. And I don't blame anyone, because those poor and vulnerable Korean elders and those poor vulnerable Vietnamese elders, they too need this shot, right? And I'm worried that because it's such a limited community, we're ending up pitting one another against each other, when really this was an opportunity to find unity and say together, not enough, this isn't fair, it's not right, I shouldn't have to go to another zip code to get it, we should all have access to it. Why was that botched? So we need to figure out what the real root cause of this problem was, and then let's not focus on that too long. What we need to do is then find the solutions to those problems we identified. And I think that's why we were so successful here at Kedron. We've been so keen on finding solutions to the challenges we have faced. We don't have time for the blame game or to say, why is there a brown person versus a black person versus a yellow person waiting in line outside?
Thank you so much.
Thank you.
And I appreciate your passion. Dr. Neighbor-Stevens?
I want to thank Dr. Abraham, and there are people who would like to get in touch with you regarding potentially a template or ideas. I was wondering if you would put your contact information in the chat box before you leave. We would really appreciate that. And there are some other questions in the chat box that are related to some things that you talked about, but I'm pretty confident they are going to be covered in the next talks. If they're not, we will come back to it, because they were very important questions. So with that, I'll turn it back over to Dr. Davis to introduce our next speaker.
Thank you all for your time.
Thank you, Dr. Abrams, for that very passionate input, and from Kedron 1.0 to 4.0. We all need to copy that template and also to walk in your few steps and try to mimic what you're doing. Thank you again. Thank you. Our next speaker is Dr. Willie Goffney. And Dr. Goffney represents the largest group of Black doctors in California, and is also a section of California that's been hard hit with the COVID virus. Dr. Goffney, by training, is a surgical oncologist in Long Beach, California. He received his undergraduate degree from Harvard and his degree medical school from Harvard. He did his residency in general surgery and surgical oncology at UCLA, and he is currently the president of the Charles R. Drew Medical Society. He has a long affiliation with the American Cancer Society, and he has been intimately involved with the community. Of note, and I want to give special kudos out to him, he too is a member of the American College of Surgeons, which we both joined enjoyed membership. But he was one of the only 27 Americans honored by the American College of Surgeons with the prestigious St. George National Award in 2013. The St. George Award recognizes outstanding volunteers who have demonstrated ongoing leadership in community mission delivery and/or governance and have significantly contributed to furthering the society's strategic goals and mission-driven programs. Dr. Goffney is intimately involved in the community and with the leadership in LA, and we welcome his input into addressing our issue of trying to bridge the national call to action to bridge the healthcare vaccine disparity gap in African American communities.
Well, thank you so much, Dr. Davis, and good afternoon, everyone.
Thank you.
I think now everyone knows why I thought that Dr. Abraham should go last. You see his passion, and having to follow him is a challenge. I'm going to try to share my screen. I think that's it. Am I up? Okay.
Yes.
So I've been asked is there inequity in COVID distribution, and you know, I had my own thoughts before I started looking into it, and let me just tell you what I found here. I talked to the LA County Department of Health, and this is their latest data. It's not even fully published yet. I think it'll probably come out tomorrow. And so this is their data through 2/4/21. What you see here is that there are a large number of Black, Asian, and an extremely large number of Hispanic people in the LA County area who have contracted COVID-19. There are also a fair number of whites, 107,000. So that's a big number. This number looks at mortality, and this is the state of affairs through February 4th again. Look at this mortality rate. For Black Americans, it's 147 per 100,000 people. Hispanic, Latino, very high, 257, compared to white Americans, where it's only 90. I mean, that's a big number too, but it's markedly higher in the Black and Hispanic and the Asian communities. And Asian here includes communities like the Filipino community. So extremely high numbers that we've been concerned about. And notice also here, what happens if you are poor? If you live in an area that has 30 to 100% poverty, so most of the people are poor, look at your mortality rates, much higher than if you are in a less poor area. So that was very significant. It worried me because I thought that we, meaning Black people, were likely to be left behind in this COVID-19 vaccine distribution. Then one morning, I was waiting to hear Dr. Abraham being interviewed on CBS, and this statistic was reported on the screen. I took a screenshot, literally, of my television. And it said here that vaccine distribution so far, as of that date, had gone 60% to white Americans, 11.5% to Hispanics, and only 5% to Black Americans. But I want you to notice here the source of the data. This is from the CDC, and this is data that was accumulated between 12/14, when the first vaccine was released, and 1/14/21. So of course this was worse. I mean, it seemed to confirm my fear. This is data similar to what Dr. Washington presented to us last week. So I called the LA County again to find out what their data is as of this moment for vaccine distribution in LA County. And initially, you know, it seemed to bear out my fears. When I looked down here at the Black American, African American rate of vaccination, was only 4.6%. But then I looked at the Asian Americans, 22.9%. I thought, well, that's not so bad. Hispanic Americans, 29.4%, and white Americans at 30.2%. And so I thought, well, this is a little odd. It seemed to confirm my fears about Black Americans being left behind. But there's some problems with this data. And so I want you all to recognize that the data that we're seeing right now from most states and even from the CDC primarily reflects that first month of vaccine distribution. And so we know that during the first period, the vaccine was targeted to frontline healthcare workers and nursing homes. These were prioritized in phase 1A per the CDC. Most of the state and the county health departments across this country followed that recommendation. And if I go back to that data, you'll see that this data was compiled as of January 23rd. Well, it was only on January 20th, so 3 days earlier, that the 65 plus age group was allowed to start receiving the vaccine. And so the data is very heavily weighted towards that initial group that was intentionally targeted because of their risk profile. Also, it should be pointed out that healthcare workers get vaccinated where they work, not necessarily where they live. And so if you work in a very busy metropolitan area like LA County, and you are a minority worker, chances are you drive in. A lot of people find the cost associated with living in LA County too high, unless you want to live in an area that might be economically underserved. And so in LA County, we have a lot of Filipino workers, a lot of Hispanic workers, and they drive in, they get vaccinated where they work, and then their numbers end up in these statistics that show here that there was a high percentage of Asian Americans and Hispanic Americans vaccinated. That's true, but they weren't necessarily all from LA County. And so it gives a sort of skewed picture for how successful we're being right now in LA County. And so the bottom line is that any type of prioritization in who gets the vaccine skews the data in such a way that it's not reflective of what's happening in the broader community. And we need to remember that. So I think there are some real challenges out there. You know, I can't say based on the data that I've seen so far that there is inequity in the distribution, but the game is changing. On January 27th of this year, our state governor, Gavin Newsom, announced that Blue Shield, the private company that had donated to his campaign heavily, would be stepping in to help manage the vaccine distribution in California. These are some of the press reports that came out. And I highlighted some words here because I want you to understand what the media was told, and on the next slide, you'll see what the company is saying. Governor Newsom said that the strategy is to efficiently and equitably administer vaccines to fight COVID-19. Paul Markovich, who runs Blue Shield, agreed with that. It was said that Blue Shield would work closely with this person, Yolanda Richardson, who is the secretary of the Government Operations Agency. And she's the person who had been leading the state's vaccine team. And so Blue Shield is supposed to work with her again to efficiently and equitably distribute a COVID-19 vaccine. I say Blue Shield's role will be to maximize the speed at which vaccinations are available across California. Again, I highlighted this with a focus on disparately affected communities. All right, sounds good so far. This is what Blue Shield said in its own press releases. They said they're designing a statewide network to accelerate equitable vaccine distribution. Once again, this word equitable. They say that they'll develop a rigorous, reliable performance management system with the ability to track all vaccines from the ordering to injection. So they want the data, right? And then their system is supposed to help them understand who is getting vaccinated in order to ensure equity. That's what they said. And so this was a little bit problematic for me. They want to receive, they want the system to be able to receive and generate comprehensive, accurate, and same-day data. They want to be able to report performance in a detailed and what they say is a transparent way. They say overall the strategy will be will include ways to reach vulnerable communities and those disproportionately affected by COVID-19. So this is what they're saying. They say that they're having ongoing meetings with key stakeholders, and they gave some examples of who those key stakeholders are. It happens in California that the California Department of Health, not the LA County, but the whole state's Department of Public Health, early on was put together. Starting in October 2020, they recognized that eventually there would be vaccines available, and there needed to be a plan for how to roll it out. And so this group was put together, and it's comprised of many different organizations, comprising the sort of the whole sphere of interest groups in California. I mean, the group is so large, I'm not sure how they actually have gotten anything done, but in point of fact, they have gotten things done, and they've done it reasonably well. So the goal of the committee was to ensure equitable vaccine distribution and allocation. But what's problematic right now is that it's not clear how this committee is supposed to interface with Blue Shield, which now, by statement of the governor, has control. And by the way, Blue Shield was brought in because the vaccine rollout in California was slow. It seemed to be lagging. Blue Shield had been very helpful with testing. Back when California was doing 2,000 tests per day, Blue Shield was brought in, and they were able to ramp the testing up to about 100,000 a day in fairly short order. And so they do have a track record, and I don't want to disparage them at all, but it's not clear how they're supposed to work with this Community Vaccine Advisory Committee. The committee, the Community Vaccine Advisory Committee, did state their position on what equitable delivery would look like. They thought that all Californians, especially those disproportionately impacted, would have equitable access. They thought that ensuring all communities, including those urban and rural, receive equitable allocations was important. They wanted to an engagement in state and community outreach education efforts to focus on awareness. They wanted to exceed high vaccination rates in all communities. So that all sounds good. They tried to plan how California would track and actually prove this equitable vaccine delivery. And they proposed to do that by focusing on resources. So some interesting ideas here that could be business opportunities for those physicians on this call and in the minority communities. They proposed that there be a pay for performance. So for someone vaccinating individuals living in the lowest healthy places index quartile census tracts, if you could deliver vaccines to those areas, there should be payment. They have proposed payment to providers for bringing vaccines to communities of color. Payments for targeted outreach, and then enhanced payments to anyone who could facilitate evening accessibility. They understand that people work and are not necessarily available during the day. They focused on how to message the need for vaccination. They came up with some good points here. They thought that highlighting the safety and benefits of the vaccine was important, that there should be an integration of the concept of everyone working together. You know, that should be part of what's being told to the community at large. They thought that there should be a focus on how the vaccine helps family and community, and that definitely in the messaging, we should be focused on addressing the potential side effects. And that there needed to be an acknowledgement of the distrust in government on the part of some people. In terms of the messengers, they recognized that doctors and medical professionals were very good messengers, especially those in the Black and Hispanic communities. They recognized that religious leaders were extremely important in some of the communities. And here they also recognized that promotores, these are trained non-medical health workers, primarily in the Hispanic community, who go out and basically knock on doors to provide information. Health navigators and other trusted community members would be good messengers. Community health workers and cultural centers would be important, and then family members and caregivers, also people available, entities available to help deliver the message. I don't want to leave out the legal and social community activists, health and social community activists. So all important. These are all very strong statements. Again, I don't know how they're supposed to interact with Blue Shield. That hasn't been defined. But so far, there is no evidence in LA County, at least, of anyone being intentionally left out or overlooked. All of the groups that are involved are publicly saying the right things. I think the goals and the approaches that they've talked about are reasonable. There is a potential, though, that we need to be careful of, that what Blue Shield is saying could end up resulting in inequity. I have a feeling, and we'll have to watch for it, that Blue Shield will start to equate the rollout or determine the rollout based simply on age, that they will leave out the risk element. You know, so far when healthcare workers, frontline healthcare workers in nursing homes were prioritized, it was because they were at highest risk for being exposed to the virus and becoming sick. And certainly for healthcare workers, that would impair the ability of the health system to deliver care to the broader community. In nursing homes, they had sort of a captive audience of people who were also happened to be elderly, and any disease that occurred in that environment could be easily spread. And so they were felt to be at extremely high risk, and it made perfect sense to put them into the group that got the vaccine first. Once the CDC said that people age 75 and older should be vaccinated, it was again recognizing that elderly people were at increased risk. And so it made sense to include them. Now that we've moved down to the group age 65 and older, we're getting more into the general population. And if Blue Shield tries to continue the rollout, basing the rollout only on age, it's going to create an inequity. That would mean that the 60-year-old person living in a 5-bedroom house in Bel Air with 2 people would have the same opportunity to be vaccinated as the 60-year-old person living in a 2-bedroom house in Inglewood with 5 people. That person in Inglewood is at much higher risk because the vaccine prevalence in that community is so much higher. And so we have to recognize that we've got to continue to focus on the risk element to determine who is vaccinated. It should not be age-based. And I would argue that everyone who lives in a poor or minority community should be considered at high risk. And they should have immediate access to the vaccine, no matter what their age is. And so that would have to be over age 16 right now, but no matter what their age is. And we should be prepared to scream and yell if Blue Shield announces, as I think they will, that the vaccine rollout will be determined by age. So they kept talking about equity. I think they're going to try to equate equality with equity. This is a slide that I've seen before. I'm sure most of you have. I took it off of the internet. And this is equality, where everyone has the same size stool, even though clearly these first two people don't need it. Even with that stool, this little guy can't see over the fence. Equity is when you use the same number of stools, so the same resource, but now you make it possible for everybody to see, all right? And so in our community, we need to look at transmission rates. We have to determine what the risk is to members of that community. And that should be the primary driver in determining how to allocate the vaccine. So I thank you for your time.
Thank you so much, Dr. Goffney. That last slide really, for the first time, gave me a lot of clarity around that issue. Let's go to the chat box. Dr. Walks, Dr. Neighbor, Janelle.
Yeah, so we have a comment from Dr. Abraham. He said, just agreeing with Dr. Goffrey. Everything Dr. Goffrey is saying is truth, and the reality, the challenges we are up against on the front lines in translation means there's a lot that don't smell right about the way the state is approaching the equitable distribution. So that was just a comment in agreement. Someone asked, what is the percentage of African Americans in the LA city population and in the LA county population? The point about Filipino and Latino workers in the LA County area appearing in the data is a critical one because there are significantly fewer African American workers and residents in the Los Angeles city, as well as in the LA County areas these days.
Well, I agree with that. And it again just points out that we can't use this early data from anywhere in the country as a true index for what's happening. We can't use that data to say that there has been inequitable distribution. I think the potential everywhere, though, is that it could, people in power can change the situation so that it becomes inequitable. But that early data is just not sufficient enough to be able to draw strong conclusions. And I think we need to be prepared to make the argument for equity and not equality. All right, it's got to be equity. And the only way to focus attention on that is to keep the discussion on the importance of risk. And risk is determined in a way by prevalence of the disease in the community. If you live in a community where there's high prevalence, you should be able to get this vaccine whether you're 30 years old, or 75, because your risk is there. Not as many 30-year-olds, of course, die from it as 75-year-olds, but your risk is there, and you can spread it around. And so I think we as organizations, physicians certainly, and just people with voices need to be aware that across the country, other governors may do what our governor did and try to turn this vaccine rollout over to larger companies. And those larger companies, in order to make it easy to generate data, could easily start talking about what's equal and what seems fair. Most people won't realize that, offering this vaccine to every 60-year-old is not equitable. Like I say, the guy living in Beverly Hills in a big house who could easily isolate, from wherever he needed to is not at the same risk as someone living in the inner city where the prevalence of the disease is high. And so, the companies, at least in our state, people keep talking about equity, and we should hold them to that.
Thank you. Dr. Neighbor Stevens, any comments, questions?
You're muted, Dr. Stevens.
Yes, I've been trying to get off mute for a few minutes. Yes, I think that, thank you so much for bringing this information. We are certainly hearing reports from around the country of similar observations and issues. But But what I was thinking was, if we think back to how this whole vaccine program launched, which was specifically, it was turned over to state governors to administer. I think what we might want to think about and discuss is how we can give feedback to the new administration and its task force for vaccine on the observations that we are making, and that perhaps the state-based delivery plan needs to be radically revised and go back to a national determined program. Dr. Abraham, I think it was Dr. Abraham, mentioned working with Representative Waters. I think we certainly need to identify sympathetic ears that we can reach out to and present the observations. And I was wondering, Dr. Goffney, what recommendations would you, if you received a phone call from President Biden tonight, because somebody was on this call and told him people in California are not happy with what's going on, what would you tell him?
Well, I would agree that a lot of people are not happy with what's going on. Right now, it's simply too hard to get a vaccine appointment. You know, I heard a term last night on the news that I had not heard before, and that was vaccine angels. And vaccine angels were basically generally younger people who are tech savvy and who have been willing to go online for their elderly neighbors or other people who simply don't know how to navigate the system in order to find appointments. I mean, my wife is in that category. She's been online for the last 2 weeks, setting up people, you know, to be vaccinated. And so it is too hard right now. If you don't have internet access, or you don't have just enough tech savvy to navigate these systems, then you're not going to be able to make an appointment, and it's going to be very difficult. And so I would agree if President Biden told me that it's craziness. I think he would agree that the whole notion of turning everything over to the states from the beginning was a faulty step. Right? The federal government should have been involved with testing. They should have been involved with procuring PPE and distributing PPE. They should certainly be involved with determining how to roll out this vaccine, and even to make sure that we have enough supply. I mean, over the years, we've debated in this country whether or not there's a role for the federal government versus state governments. You know, when this country was founded, people wanted the state governments to have a lot of control, but there clearly is a need for a big federal government. In my mind, there are many issues like this, pandemics or natural disasters, nationwide natural disasters, where the role of the federal government, I think, is important. And so, you know, I think I would say, yeah, the federal government needs to step up and do more and try to get everyone to follow a certain protocol. In the meantime, however, I would do exactly what Dr. Abraham has done. I applaud his efforts wholeheartedly. You know, figure out how to do it ourselves. You know, get hold of the vaccine, and then I would continue to make the equitable argument, or the equity argument, and vaccinate everybody in the community. I mean, we are fully on board at the Charles R. Drew Medical Society with an attempt to at least set up one other vaccine site. And we're trying to do that with the Martin Luther King Hospital. And if we could get hold of vaccines and keep the local Department of Health off of our backs because of whatever protocol they may have, I would vaccinate everybody in the community.
Let me ask
This is
go
Dr.
ahead,
Walk.
Doctor.
Dr. Maxey, let me just jump in for a quick second. As a former state health officer, I understand that money matters at times like this. We're looking at the federal government preparing to send out $1.9 trillion, and some of that money is coming to the states for vaccination programs. What the states are supposed to have is a plan for how the vaccine programs will work. It's possible to get information to the feds that say, have someone accountable for what those plans look like. Specifically, Dr. Goffney, to your point about the this what's Blue Shield going to do and how are they going to roll out? Someone at the state level needs to know that. And I think if we are able to ask the right questions to the right people, Representative Maxine Waters was mentioned. She's someone that's been asking tough questions for a long time. And I think it's reasonable to get her or someone in that position to ask the question, what is going to happen? What is the plan? And then on the federal side, you tie the money to the plan, and that's how you get the outcome that you pay for. So I think these are things that folks have been doing at that level, and I think we can just put ourselves in the middle of that, especially when you're performing well, and you guys are performing well and you have information.
Agreed. Thank you.
Okay, I think we should proceed to the next speaker. Okay, thank you, Doctor. For this federally funded vaccine, we certainly need federal government involved, and maybe a national system should be proposed that can monitor the states. Distribution to CVS, Walmarts, and local pharmacies, whereas this one close to everybody's community would help to speed up the ability to deliver this vaccine. Because as Dr. Foster said, we need 75% of Americans vaccinated to get to near normal within a year. And at the present pace in other countries, to vaccine 75% of the world with the 2-dose vaccine is going to take 6 to 8 years. And so we need to rev it up. We need to get more vaccine available. We need a 1-dose regimen. We need people at least to get some sort of immunity in so we can stop the virus. So we need to continue this dialogue, and most importantly, some way of tracking what's being done and how it's being done, and to have some sort of accountability that things are just not lost in the universe, that we're actually getting the vaccine to the people who need it. So our next speaker is Dr. William King. He comes armed with not only MD, but also JD. He has a Doctor of Law, which he attained simultaneously with his medical school degree at University of Illinois at Urbana-Champaign. Additionally, he is also a Harvard trained person. He completed internal medicine residency at Harvard Medical School's Cambridge Hospital, where he was the chief resident. He is a native of LA, and he returned to LA to complete 2 fellowships at the University of California at Los Angeles. He is board certified in internal medicine, and he also is an HIV specialist, another community hard hit with public health issues and need of vaccination and at-risk community. Doctor serves on the California-Hawaii Advisory Committee of the American Academy of HIV Medicine and his new Academy Council on Racial Equity. He also serves as a counselor at large and on the Health Equity Council of the Los Angeles County Medical Association. He is past president of the Charles R. Drew Medical Society, and he works and lectures and has been nationally recognized in his respective areas. Thank you, Doctor, for joining us, and please feel free to let us know how we can make some headway in this fight for equitable distribution and control of this virus in our hardest hit African-American community and other minority communities.
Great, thank you very much for the introduction, and thank you for the invitation to be here. May I share my screen, please?
Yes, go ahead.
Okay. Great. So what I wanted to do, besides following Dr. Goffney and Dr. Abraham, both who I work with and enjoy immensely, I wanted to give a perspective as a community-based provider. I am an internal medicine doctor. I'm in private practice, and my office sits in the Crenshaw area in SPA 6, one of the hardest hit areas in LA County with regards to both physical and mental health inequities and problems. So the issue is this, and I wanted to focus again, kind of piggyback off of what Dr. Goffney looked upon the national data with vaccines, and that was done by the CDC. One of the issues that occurs, though, is that the data has problems. 48% of the race and ethnicity data has not been reported. And that's been echoed in a recent article by the San Francisco Chronicle, where it showed the large counties of San Francisco and Sonoma County was also not reporting race and ethnicity-based data. And we know where data goes, policy goes, and then resource goes as well, too. I wanted to talk about vaccine willingness and what we do with our patients, what we do in terms of our providers as well. This is the data coming from the Kaiser Family Foundation. This is a national representative sample of 1,600 persons, 306 are Latinx, 310 are African Americans. And this is a recent survey on vaccine willingness from January 11 to January 18th in 2021. So does the public want to get a COVID vaccine? When? And when we look at the African Americans and we look at Latinos, we see that 35% and 42% of that representative sample reported that they already had received it, or they would want to get it at ASAP. When the question was asked, does the public want to get a COVID vaccine? And the answer and the question stem was definitely not. We see that about 14% of blacks, 40% of whites, 11% of Latinx individuals said definitely not.
Dr. King, I'm not seeing your slides. Are you sharing your screen?
Let me make sure about that then. Should be sharing my screen. Sorry about that.
There we go.
See that now? Great, thank you. Thank you for telling me. Okay, can you see my screen now?
Yes.
Great, thank you, Dr. Walks. Thanks for letting me know that. So what I'm seeing, this is for the Kaiser Family Foundation COVID-19 data from January 11th to January 18th. We were looking upon, the question was, do you want to get a vaccine and when? We're seeing that 35% of African Americans, 42% of Latinx individuals that already had the vaccine or reported that they wanted to get it as quickly as possible. When the question was asked again, of the people that said definitely not, we see that 14% of whites, 14% of blacks, and 11% of Latinx individuals said definitely not. What I was going to say as well too, the problem that we focus upon, this is why I like the term the vaccine hesitancy rather than the vaccine mistrust or advaxxers, because the problem that we have when we're focusing a lot of medical mistrust, which I did a lot of work on as well, is that we start to get into this trope of not reaching out to these individuals, I believe. Just like we did with hypertension, and Dr. Maxey could talk to you about that, or we're treating congestive heart failure, we started becoming almost a stereotype of what works and what doesn't work. And when we go automatically to these situations and say that medical mistrust is the issue, very important, very problematic, but we're not focusing on the issues of vaccine hesitancy as well. I think that's why the gray area is so important. We're not just going from a binary, yes, I want to get it, no, I don't want to get it. I think that's where the vaccine hesitancy comes in. And so we want to try putting a positive spin on this issue. What I'm getting from a lot of my patients want to get it, but some of my patients and fellow colleagues that want to do a wait and see approach. And that I think about in terms of the vaccine hesitancy. And we're looking again upon the same sample. We're seeing that 43% of African Americans and 37% of Latinx individuals are with this wait and see. And this is something I think that we, as public health workers and as overall healthcare workers as well, can do something with. To me, this is where we're seeing. It sits back into when any time you want to impart a change in behavior, I go back to the stages of change that we were taught about in medical school and in residency as well. The individuals who are saying no are still in that contemplation stage, but the individuals that have this vaccine hesitancy, this contemplation, these are that have some ambivalence, or these are the individuals that I think that we could work with. This is the low-hanging fruit. These are the individuals that need our education and to work with the patient-provider situations. So how do we do that? I think one of the things we need is let's meet the people where they are. The first thing I think all the time is here we are representing a package to individuals. If you come with a package to an individual, even if you've talked with them 15 to 20 minutes, maybe they see you in the store, etc. Say, here, take this package. This is good for you. But we're not telling them what's in that package. That's where transparency is very important. I've been to many of these talks, both here, internationally as well, and everybody talks about talking to your provider about the vaccine. What does your provider think? Well, we as providers, we need to be very aware about what's in the vaccine. And particularly when we're talking about the mRNA viruses as well, the mRNA virus-based vaccines. We're very good at that right now. We understand right now about the mRNA vaccine. We understand we've been able to talk about issues and say this occurs in the cytoplasm and not in the nucleus. That this is not going to change your DNA. This is not going to infect you as well too. That what this is doing is creating the spike protein so your body can do the immunological work. We also need to be prepared about these new vaccines that are coming out. The J&J vaccine, for example, and the AstraZeneca vaccine as well. These are going to be different. And I think there are going to be more questions that are going to be occurring from our patients. You had said right now that as you were talking about, this is just an mRNA vaccine and all the work it does in the cytoplasm. Well, the way of the J&J vaccine, Dr. Maxey, what I'd recommend is that for your next talk that you have your virologist talk about these new vaccines, if you haven't already, because these new vaccines are adenoviruses. They work in the DNA. They're DNA-based vectors as well too. They work inside the nucleus. So all the education that we've been doing on the mRNA vaccines are not going to pertain to the J&J vaccine as well. My other concern as well too, and I love Dr. Abraham as well too. I agree that we should try to get as many vaccines as possible. The J&J vaccine is 72% effective in terms of preventing severe disease. But if I'm in the line and I have a chance to get a 90% effective vaccine and a 72% vaccine, I'm going to get into the 92% vaccine. Right? They're also cheaper. They're going to be able to be used in doctors' offices. But cheaper, one shot, at lower efficacy as well. Where my concern is where those vaccines could be located, where they're going to be focused. We need to normalize terms. We hear the terms of Operation Warp Speed. This vaccine has been done, the mRNA vaccine has been done at incredible speed, which is amazing. But we need to break it down to our individuals, to our patients, to be able to let them know how it was done as well. Prior to this, the quickest vaccine to get to FDA approval was the mumps, and that took 4 years. But we need to let individuals know, again, that there were no stones unturned, that there were steps at every step of the way, phase 1, phase 2, phase 3, with independent data boards. We need to tell them about terms like the EUA. What does that mean? Because as people can get their information, we look at our willingness to vaccinate studies, the more information that they perceive, the more they perceive the effectiveness of the vaccine, the more the knowledge they have about the vaccine, the more willing they are to take it as well. We need to normalize the vaccination process. We need to personalize that process. This is, again, the same Kaiser Family Foundation situation. People feel that they do not have enough information about the potential side effects of the COVID-19 vaccine. We see about 67% in African Americans and 66% of Hispanics do not feel they have enough information about the potential side effects, nor do they have potential information about the effectiveness of the COVID vaccine as well. I think that we need to do this. I think that we need to share the information about it. This is myself and Dr. Derek Butler, who's another local HIV physician. This is us 5 minutes right after we received the vaccine. We reported it on our social networks. We told them the truth. as well. What happened? My first shot, I was tired. I was exhausted that first day. And I went and advertised it as well on our social media to let people know. I tell my patients about what I experienced. Second time, I had some pain in the arm. We were all doing these vaccines shots about this is our shot. We're tagging in our Twitter, on our social network as well too. We also need to be transparent about what's happening with us as well. I think that transparency goes a long way to building trust within our patients. So the social media campaigns are going to be very important. We need to write op-eds as well too. We need to let our individual papers know. The papers that, particularly papers from our community, let them know what we're doing. Let them advertise about what is happening with Dr. Abraham and the work that we're doing to try to answer questions as well. We need to try to create strong community partnerships. One of the reasons I say this is that Dr. Abraham got that community partnerships, but we need to help him more. Every time that in my office, we are basically putting vaccine appointments up with our patients. And we're doing that, but every time we do that, that takes away from seeing a patient, that takes away from putting labs, that takes away from checking eligibilities, et cetera. So we need to find ways to register our patients because again, as both Dr. Goffney and Dr. Abraham have said, there are lots of problems in terms of bandwidth. People are unable to utilize these vaccine registries as well to make appointments. So we're doing it, but we need help in terms of doing that. We need to provide transportation. We tell them where Dr. Abraham's clinic is, which is fantastic. We tell them where other locations are, but then how do I get there? That's why the idea of these mobile vans in Kedron 4.0 is going to be so important in terms of bringing basically vaccines to our patients. And we need to have these partnerships. And we need to share information as well. When I found out in December that I had access to get the vaccine, one of the first things I did was contact all my colleagues and workers because we wanted to share that information to make sure that no one was left out. The final thing that I have to say, because I only had 5 minutes, Dr. Goffney brought this up as well in terms of the equality and equity issue with regards to vaccines. But what I want to do, and I think the most important thing that we should do is focus on the liberation, removing this barrier as well. We want to make sure that more vaccines get into Black and brown arms. I don't have any problem with saying that we want to have the burden, whoever has the highest burden should be able to get quick access to these vaccines. Ideal world, I want everybody to be vaccinated, but I think we need to also, should not be ashamed if we want to say we want to prioritize Black and brown arms to be vaccinated. I was told I had 5 minutes, that's why I was very quick, but I'll stop there.
Doctor, thank you so much for your astute presentation. I've got sort of a twisted question to ask you. First of all, I had my vaccine, my second dose a week ago at Kedron with Dr. Abraham. And at age 79, I had no side effects at all. It was very good. So one question is, should I be worried that I didn't have any significant effects? And the other question, which is a little bit twisted, because I had a conversation with a very well-known personality in the nutrition field, could I have been infected by a bot?
Okay. The last thing, affected by a bot, I sincerely doubt it. I sincerely doubt it. The first, and tell me your first question again.
I had zero side effects.
I think
the next day, nothing. Should I be worried that I didn't have any problems?
I don't think so. I mean, I think that sometimes when I see in the HIV world, what happens sometimes, some of my patients say, well, the medication didn't work because it didn't make me sick. Right? Because early on in terms of the medications, AZT, et cetera, people were getting sick. And with the newer medications, there are less side effects that occur. More effective medications, however, they say, well, it didn't make me sick, it didn't make me nauseated, so it didn't work. We think that the medication has to do something to us in order to make us sick. I think you're very fortunate that it didn't happen to you, Dr. Max, and I think the transparency that you're saying that I think is very important. Now, again, like I said, my time when I had the vaccine, I was knocked out for that whole day. And it meets the guidelines. It meets what people are saying in terms of being fatigued. I've had some people that had very sore arms at the injection site as well too. Some individuals do say here that about some of the deaths that have been associated. I can't, I'm waiting for that data just like you are. I'm waiting to see what the coroner reports are saying. I'm waiting to see if there is really a correlation, but I know right now we have millions of individuals who have been vaccinated. There's very few deaths that have been reported. The majority of individuals have fatigue, they have headaches, they have pain at the injection site. Very few deaths that I've seen. And medications that we normally prescribe anyway, some people may have deaths associated with that as well. I can't account for why this unfortunate woman that got vaccinated and then was shown on YouTube died shortly after getting vaccinated. I can't account for why that individual in Orange County died 2.5 hours after receiving the vaccine. I know we want to talk about Hank Aaron as well too. I can't account for those, and I'm waiting for the data about that. But I do weigh that against the millions of individuals who've reported side effects close to what has been gathered as well too.
For example, we had a type of question in medical school, and the answer was true, but not related. And I think that some of these deaths they happen, but they have no relationship to each other. Maybe we have questions in the chat box, or our co-moderators and producer have comments.
I just want to say one thing, but I don't think that we should, and then here's the thing, I'm not trying to discount those, because I think, again, it gets to the issue of transparency as well too. I'm also just actively reading this information just like everybody else to try to see about it. But I know that all I can say is if I got my own parents who are 84 or 85-year-olds vaccinated, I would not have done that if I did not trust what I was seeing, what I was giving them.
Okay.
There's a question in the chat box. What was Bill Gates' role in the vaccinations?
I don't know that, Tori, I don't know that directly, and I try not to answer, make up answers, so I don't know that directly. I know that that's some of the issues that comes out in the community, that Bill Gates was involved. He put a lot of money, and then this is one of the ways of trying to decrease our community as well too. So whether his role in the vaccinations was different than his public health role in terms of trying to stomp out malaria, I don't know. Since I know you personally, you and I can talk about that offline. I can try to find out that information.
I want to go back to a couple of questions that I have been holding off on. I think they can be answered pretty quickly. One of the questions was, how do the states get the vaccine? What's the source of the vaccine? So I don't know if one of our speakers wants to talk about, or Dr. Walks, the distribution path for the vaccines currently.
Is Dr. Abraham?
Just very quickly, the federal government buys the vaccines and distributes them to the states. That's the answer to that question.
I thought it would be quick. This one I think is really important, and I'm actually anxiously awaiting the readiness of the new website, because I want to put this on the website. There were a couple of questions about how do you find out in your local area about vaccines? How do you sign up for it in your local areas? Do one of the speakers want to speak to that?
In LA County, I can tell you that there is a website associated with the Department of Public Health that you log on to, and basically you put in your demographic information, and it will tell you when you're eligible right now, and whether or not there are any openings at the particular locations you might want to visit. That's been part of the problem, by the way. When people want to make a vaccine, there's simply no availability. And that has to do with the number of vaccines available. And so the federal government, we know, has purchased additional vaccines. They're now going to make them available through CVS and Walgreens stores. And presumably there would be more availability for people in the community who want to go. But right now there's a shortage. There's no doubt about it. There is a shortage, and very large desire in the country to be vaccinated. Despite the numbers of people who have vaccine hesitancy, there are a whole lot more who want to be vaccinated. They recognize the importance of it. And so hopefully it'll get better over time. We don't want to lose out in the process. So that's why I'm so impressed by Dr. Abraham and his model at Kedron. Just get hold of the vaccine, forget about don't forget about, but the demographic data has to be handled by somebody else in terms of input, but he's putting shots in arms, and that's the key.
Dr. King, you want to weigh in?
Yes, I just wanted to say something real quickly. I definitely echo what Dr. Goffney is saying. The program is called CalVax. However, as both Dr. Goffney and Dr. Abraham alluded to, it's not a very easy program. In fact, so I've dedicated some of my staff, and I personally put in patients myself. Not everybody has access to getting onto internet status, to get onto the cell phones. It's only in English, it's not in Spanish. And you saw the majority of individuals in LA County are Spanish speakers. So there's lots of problems with that. And then there aren't always vaccines available as well too, in terms of appointments. That's why these partnerships with individuals like Dr. Abraham, and there's a couple other local vaccination sites, are very important, because we have to sometimes pick up the phone and work with them. And you see Dr. Abraham is passionate and dedicated to getting shots in Black and brown arms. And so we have to get them there. We have to get those Black and brown bodies to them. Because sometimes it may happen, he called me the other day and said, we have 600 vaccines available. They're about to expire. So we pretty much shut down my clinic, and we started putting people appointments to get them over to Dr. Abraham's office.
Thank you, Dr. King. Dr. Maxey wants me to give a little preview of what you can expect in the next few weeks. I'm going to ask Dr. Walks to give us a little. Dr. Walks, you had your finger up?
I had my finger up just real quickly before we leave this, because we've been talking about Los Angeles and we talked to a national audience. And I just want to say that the one thing about public health is that it varies so much from state to state and oftentimes from county to county. So check with your county health department, check with your state health department for how the vaccine is being rolled out in your area. And also, people who are veterans, the VA is vaccinating veterans on its own outside of the state regulation. So look to see if you meet the VA age requirements, if you happen to be a veteran like I am. A lot of people can get their vaccine different ways. It doesn't only have to be wait until you meet an age requirement or you meet a frontline worker requirement. So just be aggressive about getting it. Check with your local health department, county, state.
Kaiser Health System has apparently gotten a direct allocation as well, and their intent is to vaccinate their members. So if you happen to be a Kaiser patient, you can get a vaccine, be vaccinated there.
So back to you, Dr. Walks. Can you give a little tease about what we're planning for next week? And then I'll talk about another week in the future.
I don't want to say give a little tease, because next week we're talking about Black love. And I know Dr. Maxey is going to start smiling right now. So
Right.
next Sunday is Valentine's Day. We have been hit psychologically, and one of our speakers mentioned this earlier. We've been hit right in the psychology with what's been happening the last year with the pandemic. A lot of issues that we've dealt with, and in the middle of all of that, next Sunday is still Valentine's Day, and it's still an opportunity for us to talk about some of the mental health consequences and its impact on our relationships and how we relate to each other. So that's a little bit of a tease for next week.
All righty, and then I'm going to try to tease you a little more. In 2 weeks, we're going to be talking about obesity and COVID. Now, I know you have heard in the past that obesity is considered and is one of the comorbidities that puts you at an increased risk for a particularly severe episode of COVID. So what we're going to be talking about, though, in a couple of weeks is obesity and COVID from a bunch of different perspectives: pregnancy, joint health, cancer, and treatment. So I want you to make a mental note that that will be our focus the last week in February.
And I believe that show is produced by Dr. Cutter, who's a very well-known oncologic surgeon, as is Dr. Goffney. In fact, she's the president-elect of the Drew Medical Society. There's a group of physicians, and I'm inviting other physicians and health professionals to join us. And we've joined an organization called Biometrics Second Opinion Expert. And we not only provide second opinions and first opinions, but for the next several months, we are providing free information or consultation if you have questions about whether or not it's advisable for you to have a vaccination and you don't have your own health professional. And we know that a lot of our patients get their health care at emergency rooms and urgent care centers, but we want to be your trusted source of physicians who can discuss with you your risk factors, et cetera, and provide you with a recommendation. For physicians who'd like to join that, we know that many of our practices are less, and we want to expand our ability to provide service, and you will be reimbursed for this. So you can reach out to biometrics.secondopinionexpert.com or reach me, and we will help provide that service. I'd like to thank Dr. Neighbor Stevens and Dr. Ivan Walks for being the co-moderators, and I'd like to give special kudos to Dr. Helen Davis for putting this very informative program together. And Dr. Davis, if you have a final short statement, and then Dr. Neighbor Stevens and Dr. Walks, and then we can go and watch the Super Bowl.
Yes, I think our Super Bowl takeaway message is we need to prioritize getting the vaccine in Black and brown arms. We, as trusted doctors, we need to share information. We need to be transparent. We need to participate in op-eds and things like that. We need to create the community partnerships, as our doctors alluded to, and we need to help our folks get registered. So whatever it takes to provide transportation, lend a hand, we need to help and try to help bridge the disparity gap by doing our extra part and going beyond the call of duty to help bring this pandemic to an end. And thank you all for your participation and all the valuable information you share with the audience.
Yeah.
Dr. Walks?
I would like to just really thank Dr. Davis and the other members of the panel, Dr. Goffney, Dr. King, just all of you, because we speak to an audience that is composed of doctors and health professionals, but also folks who are not doctors. And so the clarity, the openness with which you present, and also the emotion and the caring that comes through when, you know, Dr. Abraham called and he had these doses and we got our people, and this is the kind of thing that lets people know that we still care about them. We're doctors, and we are people, and we have families and people and communities we care about. So I just want to applaud all of you for the work that you're doing. I think it's just important that people see this side of us. It's not all degrees on the wall. So thank you all.
Dr. Neighbor?
I just want to wish everyone be safe this week. Remember the same old, wear that mask, 1 or 2 or 3, but at least 1. Wash those hands and keep your distance so that we can be together again next week.
Let me ask, I see a hand. Is Mr. William Dickerson still on? He works with Jesse Jackson and Rainbow, and his hand has been up there, I think. Is Mr. Dickerson on? You had a comment or question, sir?
I didn't have a comment with Dr. Maxey. I have enjoyed the presentations. Thank you.
Okay, well, and thank you so much for being of support to the Black Health Trust. And one last thing, I saw a number of our officials from the NMA, and I noticed our president-elect was on. I hope she's still on. Would you care to make a brief comment, Dr. Villanueva?
Please unmute Dr. Villanueva.
Is she on?
Please unmute Dr. Villanueva. She's on.
Sending her the unmute.
Okay. Can we do it? Dr. Villanueva is a physician who practices OBGYN in the wonderful city of New York, where I left a bunch of years ago for the warmth. But we salute her for being on, and a number of other past presidents I noted of the NMA, Dr. Gary Dennis, usually Dr. Richard Williams, and others on. But I thank you all so much for being a part, and I'd like, is Ms. Brenda Lee Yeager on?
Say the name again, doctor. Issues.
Hold on just a little while longer. Hold on just a little while longer. Hold on just a little while longer. Everything's gonna be all right. If I didn't believe that, I wouldn't say it. So until we meet again, thank you, doctors. Thank you so much. I learned more. I love you, and I thank God for you. And until we meet again, Dr. Maxey, Dr. Goffney, Dr. Norbert, Dr. Walt, Dr. King, all of you, thank you so much on behalf of all the rest of us. God bless you. See you next week.
Thank you. And may the LA Rams win the Super Bowl today. Have a good night, everybody.
Bye-bye.
Rev pointer.
Hello, my brother. How are you?